It involves non-treatment related activities and supports for long-term wellness for folks who do not need treatment. It can accompany treatment to enhance the strength and ability of recovery initiation. And in many cases, it can provide post-treatment recovery support services to enhance the durability and quality of recovery maintenance. So it's this shift from putting people through numerous acute treatment that focuses on the acute phase, the acute problems of the disorder, and looking at the solution as one that is more chronic and requires long-term sustained support that is of lesser intensity and less cost over time. Recovery support services are non-clinical services that assist individuals and families to recover from alcohol or drug problems. They include social support, linkages to and coordination among allied service providers, a full range of human services that facilitate recovery and wellness, contributing to an improved quality of life. Now, services like these can be flexibly staged and can be provided, as I said, prior to, during, instead of, or after treatment. Recovery support services can be provided in conjunction with treatment and as separate, distinct services to individuals and their families. These services are typically provided by volunteers and sometimes paid staff members who are familiar with their community's support for people who are seeking to live without alcohol or other drug problems. Often recovery support services are provided by peers, people in recovery or family members. Some services require reimbursement, while others, such as mutual support groups, may be available for the community free of charge. Recovery support services are not treatment. We want to distinguish them from professional addiction treatment services. Professional services are provided by individuals with formal education in a clinical or medical setting. Professionally directed treatment providers are accredited and licensed to provide the services, and the staff and counselors are credentialed, licensed, or certified. While some addiction professionals in long-term recovery may volunteer to provide recovery support services, they wouldn't be acting in their professional capacity. If they took on this role, they would need to rather rigorously manage issues of role ambiguity and conflict. Recovery support services are not the same as mutual aid, as 12-step or faith-based or other kinds of mutual aid programs like SMART recovery. Mutual aid is provided in a group setting by individuals with experiential knowledge within a particular community of recovery. It's a particular pathway. In a mutual aid setting, support is based on the beliefs and practices of a particular recovery fellowship, such as AA or SMART recovery. Service work, quote-unquote service work in the context of mutual aid, differs from peer recovery support services because it's based on a particular fellowship and part of a personal program of recovery. Some people who are peers and or receiving peer recovery support services are also members of mutual aid groups. Their work as a peer helper is distinguished from the service work they may perform in their particular recovery fellowship. Peer recovery support services should not replace support provided by sponsors and other indigenous community support resources. So peers serve functions that are different from, say, sponsors that are found in 12-step mutual aid groups. Sponsors generally operate in relative isolation from professionals. Sponsors provide support on a particular pathway, emphasizing the viability and superiority of the particular program or fellowship. Sponsors support is limited to those who have sought help within that particular fellowship. Sponsors' primary focus is on the use of tools that are particular to that pathway and personal experience, things like personal storytelling, meetings, step work, literature, etc. Sponsors aren't allowed to be reimbursed for their support, and sponsors are guided by historical and contemporary practice as expressed through the literature on sponsorship as expressed in that particular group's conscience or traditions of the fellowship. So when we talk about recovery support services, peer recovery support services, these are not the same as treatment and they are not mutual aid. There are a number of types of recovery support services that have been identified. These include emotional, informational, instrumental, and affiliational. So emotional is demonstrating empathy, warmth, things like mentoring, coaching, support groups. Informational would be things like providing knowledge, information, and skills, life training, job skills, balancing a checkbook, keeping a budget, citizenship restoration, making out a resume, filling out a job application, those kinds of things. Instrumental is concrete assistance to help folks get things done, transporting them to support groups, child care, clothing, helping them work with job seeking and completing resumes, etc. And affiliational is connectedness with others, more social group or a community, establishing a positive identity. Things like having alcohol and drug-free socializing, community building, cultural activities that promote healthy norms and connection to non-substance using communities. Peer leaders can provide social support services to individuals at all stages of the continuum of change that constitutes the recovery process. These services can, as we said, precede formal treatment, accompany treatment, be in place of treatment, or follow treatment. Who are peer specialists? A peer specialist is a person with lived experience who has also been trained and employed to offer peer support to people with substance use disorder or mental health disorders. They can do these in a variety of settings. They can range from homeless outreach and shelters, soup kitchens on the street, to being part of a multidisciplinary inpatient, intensive outpatient, or ambulatory team. Sometimes they're called peer recovery support specialists. The primary distinction is that they have lived experience in the process of recovery and have been trained how to use and talk about that experience to help others in a non-particular pathway to recovery. There are many pathways to wellness. Mutual aid groups, by and large, address a particular pathway towards recovery. Peer specialists support any pathway to recovery. Recovery management and peer support focus on strengths and resiliencies. As a field, we're pretty good at identifying and articulating, listing what's wrong with folks. In fact, the assessment process that we have in treatment now is mostly pathologically focused. Part of what we need to do to build recovery support is to focus on strengths and resiliencies. The natural strengths that folks have, some of which they do not know they have, recovery assets, recovery capital, that they don't know is available or that they know is available and they cannot access, and building on these. It's a very strength-based focus and helps builds people's resiliency. What are the values of peer support services? Well, they can fill a long recognized need for services to support recovery after an individual leaves treatment, what we used to call aftercare, and then called continuing care. In addition, peer recovery support services can be a link between systems that treat substance use disorders in a clinical setting and the larger communities in which people seeking to achieve and sustain recovery actually live. Recovery takes place in a community, not in a treatment center, not in a mutual aid group. Recovery lives where we live, work, and play. Using a non-medical model in which social services are provided by peer leaders who have experienced a substance use disorder and recovery, these services extend the continuum of care and support that's provided to people, in some cases post-treatment, in other cases instead of treatment. The services are very adaptable, operating with diverse populations at diverse stages of recovery through different pathways to recovery, different service settings, and so forth. Again, they build on resources that exist within the individual and in the community, including diverse communities of recovering people who wish to be of service. By serving as role models for recovery, providing mentoring and coaching, connecting people to needed services and community supports, and helping in the process of establishing new social networks that are supportive of recovery, peer leaders make recovery a real presence in their communities and are role models who send a message of hope, provide a message of hope that's very apparent to those around them. The goals of peer support are to increase opportunities for wellness, including connection to treatment if necessary, to reduce the obstacles to continued engagement in services and supports, and to increase people's abilities to sustain their recovery following treatment. Those are the primary goals of peer support. Core supports that they provide, encouragement of self-determination, personal responsibility, dealing with health and wellness, handling hopelessness. This is where lived experience comes in. Communication with providers, managing their illness, addressing stigma, developing friendships, providing support for careers through education and employment, helping folks build their leisure and social activities, getting connected with transportation systems, developing friendships, joining groups, attending leisure and recreational activities, finding hobbies, discovering who I am as a person living in recovery. And also things around intimacy supports, parenting, family relationships, dating, spirituality, and religious supports. These are all core elements of what peer specialists, the kinds of services that they can provide. There are a variety of recovery support services. They can fall into a number of different categories and delivered across a full spectrum of recovery, regardless of whether or not a person uses clinical services. So things like one-on-one support that includes mentoring, recovery coaching, group support that provides emotional, educational, spiritual support, life skills, learning life skills, having access to computers for a job search or typing a resume. Resource connection. Housing, which is a major issue for folks with addiction who are coming into recovery. Food and clothing, transportation, another big issue. General skill development, GED for some folks, other kinds of vocational education and employment support for people. Recovery development skills, those things that are related specifically and particularly to managing one's long-term recovery, things like reducing stress, building spirituality and meditation skills, relationship and families, connecting with communities. Attending, participating in sober social activities, alcohol and other drug-free social activities. And finally, leadership, volunteering, service opportunities, building new skills, learning how to reconnect with one's community. These are part of the variety of support services that can be provided, recovery support services that can be provided. The role of a recovery coach, that person is trained to serve as a personal guide and mentor for people seeking or already in recovery. Again, regardless of the pathway to recovery. Coaches provide emotional support, assisting with setting recovery goals, developing recovery plans, helping people restructure their life and daily schedule to accommodate recovery, developing new friendships, new connections, new networks, forming and improving life skills, gaining access to services and resources. The recovery coach, however, does not perform mutual aid service work, but may link individuals to mutual aid support groups. Some of the characteristics of effective peers are that they are able to support many pathways to recovery. They can work in partnership and consultation with other peers. They focus on the interpersonal rather than the intrapersonal. They have in-depth knowledge of the local community and natural and formal recovery supports. And they have effectively sustained their own recovery. So peer recovery support services, peer specialists support a recovery management perspective that can provide support prior to treatment, be ancillary to treatment, be in place of treatment for those who don't need treatment, and be a follow-up to treatment. I'm going to backtrack now a number of slides so we can go back and look at the beginning of SBIRT, talk about SBIRT. So we're saying it's a 4-part process: universal screening, brief intervention, brief therapy, and I would say at this point we would put in referral to peer recovery support services, and then referral to treatment, that it fits in there as a response to a mid-level of severity for folks who need more than brief therapy, or maybe something in addition to brief therapy, who may not need treatment, who may not be able to access treatment, or who can use recovery support services in addition to treatment. That's really the end of my formal presentation. Do we have questions, thoughts from people about this idea?
I think we might have a few. I did see a comment in the questions panel that I was asking. Was there something, a clarification that needed to be made, because you might have said something that somebody wanted to emphasize the point that it was major. I don't know if that means anything to you.
No, I don't recall.
All right. So maybe that person will type in if there needs to be more of a clarification. Then people were asking about if your PowerPoint notes will be sent since your PowerPoints are visual. So
Yes.
Steve, yeah, we have those note pages, and so we will send those. I have to admit, trying to multitask. I was looking up the study because we're going to try to email that out as a link to the study so that people can read more information about that study.
Okay.
From what I was reading, I can see that it was a large sample size of, I think maybe over 40,000 people responded. So that's
well, and there are numerous other studies, the Sobels, Cunningham, Stanton Peele, who was mentioned, over the last 20 or 25 years have had numerous studies on what they call natural recovery. And the numbers that they get, and they're much smaller sample sizes, the numbers that they get vary from 40 to 80% of folks saying they achieved a level of wellness that was okay with them without using treatment or mutual aid. Another part of this discussion is what is recovery and who gets to decide what recovery is for him or her.
Okay. Well, we have a couple people raised their hands, so I'll unmute you in a second. But before we do that, Steve, I do have a couple comments that I could read out in questions from the questions panel.
Sure.
So I'm going to start the questions panel. I'm wondering what organizations are implementing these types of recovery processes.
Well, it's diverse. In some cases, treatment providers are. There are recovery community organizations and recovery community centers across the country that are implementing them. You can find out about recovery community organizations at facesandvoicesofrecovery.org. That's facesandvoicesofrecovery.org. And they have, Faces and Voices has an Association of Recovery Community Organizations, and you can find out more about that on their website. There are also recovery community centers, which are like senior centers for folks in recovery. I don't know that there's an actual list of those, but if you go to your state or local recovery community organization, they can probably connect you with whatever recovery community centers are nearby. And again, a number of treatment providers are using recovery support specialists, peer recovery support specialists as an add-on and intensification of treatment.
Okay, that's great. And again, we could send a link to Faces and Voices too.
Yep.
But this is definitely a movement that is going through, that states are going through, and so more and more states are purposefully looking at recovery supports, peer supports. We have a certification here in Pennsylvania. Other states have recovery, support certifications, peer support certification. We have a couple more comments, 2 questions that are similar. How long does a person need to be in recovery before being able to become a peer support person? And then the same one was, is there a recommended length of time to act as someone's recovery coach or peer mentor compared to a sponsor? When should the relationship end? So I guess they're not similar questions.
Yeah.
They're 2 questions, sorry.
The first one, I think that varies depending on the jurisdiction, and that some of that may be written into the certification processes. On the other hand, we need to distinguish between recovery support specialists and peer recovery support specialists. Peers have lived experience. They don't just know the community, they don't just know the issue. They have lived experience with both the problem and the solution. So folks probably, quote unquote, need to be in recovery long enough to have enough recovery to share, enough knowledge and understanding of the recovery process in order to have something to give to others. That's got to differ from person to person. but I would think that various treatment providers and/or credentialing organizations have either recommendations or requirements within their procedures. In terms of how long, that really depends on the person and how long to be in connection. It depends on the severity of the problem, the needs of the person, the skills of the recovery coach, peer specialist. There's a lot that would go into making that decision.
Steve, Mr. Conway has another comment, so I'm going to go ahead and unmute you.
Okay.
Lucius?
Hello, Steve and
Yes.
Holly. Thank you. The great presentation. I appreciate all that you have presented. My question is: Are you suggesting that in the SBIRT context, that as opposed to it being screening, brief intervention, referral to treatment, it be screening, brief intervention, referral to recovery support and/or treatment based on the level of the level of I guess intensity.
Severity?
Yeah, the level of severity, exactly.
Sure. Yes, and if we can get all those initials together, that would be great.
Okay.
Yes,
All right.
I think what I'm suggesting, more than suggesting, is that there's a range of severity. So I think in order to be effective, we need to have a range of response.
And I totally agree with it. It makes perfect sense. My next question is: how do we get the established traditional provider community? I mean, I'm here in New York City, and our 822 outpatient clinics are now cleared to take to facilitate the development of the recovery coach, the recovery planning process and all of that. But that's ancillary to treatment as opposed to, and then the state is also requiring those of us who are recovery coaches or peer recovery specialists to have 750 hours of SBIRT training in order to be able to administer SBIRT questions, to do the SBIRT testing.
Right.
They're requiring us to have 750 hours of that to do it. But the thing is, in the current context, we don't even have SBIRT like fully implemented into our traditional provider, certainly not in our primary care.
I'm sorry, we're losing it.
Yeah, we lose your audio every once in a while.
I'm sorry. We don't have SBIRT in our primary care provider system at this point. So we endorse it, and we're telling people they have to have it. Our case acts, our substance abuse counselors are trained to do it, but it's not being done overall by and large at this point. And so now I agree with what you're suggesting. It makes perfect sense. But how do we advocate for that, per se, in our state?
Well, on the one hand, and this sounds sort of awful to say, I'm sort of glad that SBIRT hasn't taken off the way it could, because we haven't organized a response for that we need. We don't have a continuum of care or a workforce that can respond to increased need.
Mm-hmm.
Secondly, when we talk about the recovery movement, an essential part of that, from my perspective, is the engagement and activity of the recovery community to recreate a system that's viable. There are 25 million, an estimated 25 million Americans in recovery, many of whom follow a tradition of anonymity, which they think means not to talk about recovery publicly. That isn't what the tradition means at all. We can talk as much as we want about being in recovery and the needs of recovery people. We just don't talk about what particular pathway that we take in that process. But we need to get an organized, clear, dynamic voice organized to change the system. to create recovery community organizations, to create recovery community centers, to lobby legislators about our needs. I had the pleasure of being the board chair of Faces and Voices, and the message that I would constantly deliver with the recovery community is by our silence, we let other people define us. We can't blame legislators, policymakers, money givers, grantors. We can't blame them for whatever positions they take around treatment and recovery, addiction and recovery, if we have not told them who we are and what we need. So I think that that's part of the answer as well, to build a constituency of consequence that speaks out about what our need is. And I don't know, Lucius, if that is part of what you wanted to hear, but for me it's part of the answer.
Thank you so much. I appreciate you, and thanks again.
Oh, thank you. Now, Steve, just two comments about one thing that Lucius said, and then because just from our training experience on SBIRT as a national SBIRT, that two things really. First, we do have a project with addiction treatment providers in a state that is servicing a special group. Now, this is a special population, but they are providing SBIRT services. And we train them about this whole continuum of use, problem use, binge use, problematic use, misuse, and said, you know, you're not going to be treating them the same way you would with somebody who has a diagnosable substance use disorder. Mm-hmm. And so far we've been doing the training probably for 6 months, and we're live, and we're starting to see the providers see this group. And from the training perspective, from the providers were like, well, you know what, this is nice, because sometimes we do see people who we can tell don't have a substance use disorder, but their use has become so problematic, their only recourse is to come for full-fledged, full-force treatment in your face the way we know it. Mm-hmm. So they were very happy to have this whole continuum of use and interventions, brief interventions. A couple states call it extended brief interventions, you know, if they're more than one and they're a little bit lengthier. And so that's one thing I want to share with the group. The other thing is about the primary care and how we're not completely ready for SBIRT. I mean, sometimes the cart gets before the horse. Yep. And we are lucky in a way that it hasn't taken off because we know there's access issues already. So, you know, that it's just something we have to reflect on, and it's a blessing. And you know, one of our advisory board members has suggested that the peer supports that are becoming more formalized in many states could be a very good resource for this group of people in the continuum of use, and for people who might have a substance use disorder but can't get into treatment for whatever reason, and or maybe they would feel better getting a different form of, you know, addressing their addictions issues.
Right.
The other couple things that came in on the question board, as somebody was clarifying about major, is that for recovery, jobs and life skills are major and reestablishing. Major points of, you know, life skills you have to reestablish. I don't know if you want to say anything more on that.
When we were first getting a recovery community center going here in Rhode Island, we did a number of key informant interviews and focus groups, and the issues that came up from the recovery community were jobs and education, housing, and legal issues. I think those were the top 3 problems for getting life sort of straightened out and supporting recovery. So, yeah, I think that those are major issues. Another one, let's see, money, jobs, legal issues, housing, and transportation is another one that shows up quite often. These are impediments to folks living, quote-unquote, regular lives, you know, being able to get around when you need to, as you need to, and it's part of what we think of as social capital. Yes, I agree that that's a major part.
The other thing that came on the questions panel, which is nice, is that SAMHSA might have a list of states that have recovery support organizations, do you think, or just basically?
Oh, is that a question? Do they have? I don't.
No, I'm asking, somebody suggested that maybe SAMHSA has a list,
Yeah, I don't think so.
but Faces and Voices would.
Yes, yes.
Okay, so we'll send that link out. Let's see. And then somebody was agreeing with you about the silence of the recovery community is harmful.
Yes. It's a big issue, particularly now that we know the size, or an estimated size, a guesstimate of the size of the recovery community. And many of these folks might not put their hands up and say, I'm in recovery, because they don't think about it that way. But folks who had a problem, who no longer have a problem, now that we know how many of us there are, it seems frustrating not to be able to create what Faces and Voices calls a constituency of consequence, to organize us enough to have the same kind of voice that other chronic diseases have. If you look at breast cancer, if you look at other forms of cancer, the pink stuff from, was it Comer? I can't think of the name. And then the yellow bands from Armstrong's organization, and how the Heart Association and diabetes and asthma, they all have big organizations that are very public, with very public fundraisers. We don't. We don't, and we have to come out from under that bushel barrel and operate in the daylight, I think.
Very true, and it's also inspiring.
It is. It is. Well, and this is the very end of Recovery Month. We had recovery rallies all across the country, and I'm very pleased to say that the national hub for the recovery rallies was here in Providence last Saturday, with several thousands of people here from across the country, from Rhode Island and across the country, celebrating being in recovery.
And we know that SAMHSA does have the Recovery Month website, so people could find out, if you're not aware of that on this webinar, you could see what each state did if people submitted their events, which there's something for every state.
Yep.
I don't see any other questions, and I do not see any hands raised. I don't know if there's any summary concluding statements you want to make, but
I'd just like to get all those initials for adding recovery support services, et cetera, to SBIRT.
Well, I shared with you that we want to more formally embed that into our trainings on SBIRT. Right. We have that. We have been adding to that, and we have, had experience with it, but we will talk with you about that. Sure. And I think just for people who are implementing SBIRT, to remember for the referral to treatment piece that, it does not have to be the formal treatment system. And that people's light bulb kind of goes off in their mind if they say, well, oh, I could tell my patient was motivated to make a change, yet we know they can't get in treatment. But if I ask them what other supports, or what in the past they found supportive, like a friend or a church organization, that you could enhance their motivation by connecting them with that, and putting them on as a safety net to keep that motivation going towards making changes, even small changes.
Yes, absolutely.
Well, Steve, thank you so much. I don't want to hold everybody. We can dismiss if there's no other questions or statements. Melva, do you have any closing announcements? Are you muted, Melva? I can't. I'm not sure everybody heard that. I could hear it through my door, but not through the system. I think Melva was saying that the PowerPoints will be emailed to you post-session, as well as a survey link. We really need your feedback. We always appreciate it. And so there'll be a link to a survey. It doesn't take any more than 2 minutes. I've timed myself taking it. And so we do look at that and improve our surveys as a result. We improve our trainings as a result of you filling out the survey. So thank you so much, Steve, for your presentation, and
Thank you.
we appreciate your time, and everybody on the webinar. Have a great weekend.
Thank you. Bye-bye.
Bye-bye.